Hi, today I'll be talking on one of the important disease conditions in our practice, urticaria and its management. Allergic diseases overall are common among the general population. Among these, urticaria and specifically chronic urticaria is likely to affect up to 20% of the population during their lifetime. Commonly presenting with pruritic wheal and flare reaction, which may be associated with angioedema, it can also cause pain for some patients. Factors triggering the onset of urticaria can be identified in some, but the disease is idiopathic in 50 to 80% of all cases. Through this understanding, our best option to manage this condition is to avoid identifiable triggers, but mainly to counter the allergic pathophysiology of urticaria using antihistamines. While all international guidelines recommend non-sedating second-generation antihistamines as first line of treatment for urticaria, it's difficult to select the ideal one as the commonly prescribed ones lacks efficacy, for which we need to add or updose the currently available antihistamines according to patient profiles. Today, I would be talking on bilastine, which is a new second-generation H1 antihistamine with ideal characteristics that has been recently launched in India. Bilastine has been approved in more than 100 countries globally with large and extensive clinical data conducted on more than 5,000 individuals and more than 22 million patients using bilastine worldwide. Bilastine is considered as the first choice antihistamine amongst Asia's Pacific physicians. ARIA recommends bilastine as the highest scoring antihistamine amongst all other second-generation antihistamines, and it is the only one to achieve a perfect 10 in the antihistamine scorecard. In India, bilastine has recently been approved for the symptomatic treatment of allergic rhinitis and chronic urticaria in patients older than 12 years of age. Bilastine 20 mg comes in once daily dosage, which is effective in managing symptoms, considering its quicker onset of action than cetirizine and longer duration of action than fexofenadine, making it a potentially attractive therapeutic option. Bilastine's efficacy vis-a-vis levocetirizine are backed by studies which state its superiority in the percentage of symptom-free patients, response rates, and health-related quality of life. When it comes to efficacy, bilastine has high specificity for H1 receptors, 3 and 6 times higher than for cetirizine and fexofenadine respectively. It has rapid and sustained action with an 8-hour duration of maximum effect and significant activity for at least 24 hours following a single dose, making it an ideal choice amongst other second-generation antihistamines. Bilastine is an ideal antihistamine for updosing in difficult-to-treat urticaria as recommended by the EACI, GALLAN, EDF and World Allergy Organization guidelines for the management of urticaria. Bilastine has a Tmax of 1.13 hours, while the absolute bioavailability is 61%. Its half-life is estimated at 14.5 hours, while the published values for cetirizine and levocetirizine is 8 to 10 hours. APAC review on the selection of optimal second-generation antihistamines for urticaria in Asia has also given its support to bilastine's safety. Bilastine's robust clinical essays and studies in healthy volunteers, along with the accumulated clinical experience, show that bilastine has a profile of adverse events similar to that of placebo and does not appear to significantly influence cardiac conduction, alertness, or driving ability, even in doses up to 40 mg. Bilastine does not prolong the QT-QTC interval and does not cause significant changes on the ECG at therapeutic and supratherapeutic doses, making it an ideal choice with regard to cardiac safety concerns. Considering bilastine's pharmacokinetic profile, it does not have any CYP450 mediated drug-drug interactions. It is also not necessary to make dose adjustments in patients over 65 years or in patients with renal or hepatic impairment. Bilastine has a low potential for CNS impairment when co-administered with alcohol and other CNS depressants. At therapeutic doses, bilastine does not have anticholinergic effects and does not affect psychomotor performance. It has a good substrate for PGP, which would limit its passage across the blood-brain barrier into the brain. As it shows relatively zero brain H1 receptor occupancy compared to others, incidence of sedation with bilastine is similar even in dosage 4 times the approved dose. Studies have shown that it doesn't have any effect on driving ability, flying conditions, or cognitive impairment, as is seen with other antihistamines. In fact, during on-the-road driving test studies, bilastine does not show significant differences versus placebo. Even when tested in stimulated conditions of high-speed driving of a Formula One car, operating heavy machinery, and in pilots, bilastine did not induce significant sedative effects. An active control arm study comparing hydroxyzine with standard doses of bilastine 20 mg once daily and higher dosage of bilastine 40 and even 80 mg once a daily found no significant effects on various objective measures of psychomotor and driving performance at all doses. As a clinician, I look forward to use bilastine as it checks most of the boxes for the qualities needed in an antihistamine. Bilastine has been acknowledged for use by guidelines such as ARIA as the only one to achieve a perfect 10 in the antihistamine scorecard and has also been scrutinized to become the first choice antihistamine amongst Asian-Pacific physicians.